Okay, so today we have Dr. Rosemary Batt. She is the Alice Hanson Cook Professor of Women and Work at the ILR School in Cornell. She received her bachelor's from Cornell and her PhD from the Sloan School of Management at MIT. She previously coordinated the Global Call Center project. She has co-authored with Eileen Appelbaum Private Equity at Work in 2014 and The New American Workplace, and she was co-editor of the Oxford Handbook on Work and Organization, along with over 100 book chapters and articles on management and employment relation issues that have appeared in journals such as the Academy of Management Journal, Industrial and Labor Relations Review, International Journal of Human Resource Management, and more. Her recent research focuses on the processes and outcomes of financialization in healthcare, and her work examines new forms of ownership, including private equity, franchising, outsourcing, and subcontracting of work. She specializes in management and employment relations in service industries, especially healthcare and other essential services. And it's really good to have you, Dr. Batt.
Thank you, Lauren. Okay, so I want to get started. I know we have a lot to cover today, and I'm very happy to be here. I think it's really important that you students are trying to learn about financialization and the broader political and economic forces that are shaping healthcare today. And that's what we're going to focus on. I'm going to start sharing slides, and please let me know if this works. And also, please stop me whenever you want, because this is going to be unfamiliar territory. It was unfamiliar to me until I started getting into it. And so I know what the learning curve is. I know that it's confusing. So just stop me at any time, raise your hand, or flag me, and I'll go over material again. So let me see if I can get the Zoom working correctly. First do the Zoom, and I assume, Lauren, you've given me sharing responsibilities. Yes. Okay. Does that work for folks? Can you see the screen?
We can see you.
Okay, great. So as Lauren mentioned, I've done most of this work with Eileen Appelbaum, who is at the Center for Economic and Policy Research. We've worked together on many things for over 30 years. So we know each other well, and we share in all of this work. And this is joint work that I'm presenting today. So let me get right into it. First of all, financialization is an awkward word. It's a big word. So what does it mean? And to simplify, it is simply the increased role of financial sector in the overall economy, and the increased role of financial actors, strategies, and calculations in what we call Main Street companies. And in this case, it's healthcare organizations. So what we're seeing is that the financial sector is increasingly making profits by dipping its hand into the healthcare sector. And then that means that the healthcare mission is sometimes sidelined for financial calculations in order to make more money than the organization would otherwise make. And that money goes to the investors, to Wall Street actors, rather than being plowed back into the healthcare system in order to make healthcare more effective. So I'm going to talk specifically about private equity because it's the leading actor. So we see these financial strategies across many organizations that are owned by different entities, including nonprofits. But private equity is the leading actor, and it is these firms are in some ways creating strategies that then other people mimic as they move forward. So let me focus on private equity, and that is defined as there are three components. Private equity is simply investment funds. Private equity firms raise investment funds, and there are three types. One is called distressed investing, and that is only 2% of capital, and that's where you take over a company that's about to go bankrupt. Growth equity is simply acting like a purchaser of stock. About 20% of the capital goes into just investing money in existing for-profit organizations that are traded on the stock market. And then the third are what are called buyout funds. And those are the ones that are most damaging, and those are the ones we're going to focus on. And that's almost 80% of the capital that is raised in private equity. Okay, so we're going to focus on what is called the leveraged buyout model. So that's 80% of the capital. And I'm first going to show you what the general model looks like, and then we'll see how it's applied to healthcare. Okay, so the core features of the private equity buyout model are that they first raise money to buy out Main Street companies, again, healthcare organizations, and their financials are completely non-transparent. There's no public accountability. So unlike a, say, for-profit publicly traded corporation that would have to file with the Securities and Exchange Commission and show all of their financials to the public, to investors, private equity funds don't have to do that. They submit very minimal reports to the SEC, and those are not made public. And they increasingly use what are called private credit markets, not traditional banks for loans. So for example, if the private equity fund is going to use a lot of debt in buying out something, normally it would go to a bank, and then you would be able to see how much money it is borrowing, and that would be more transparent. But if they are, for example, getting loans from each other, then we don't even see what those financial transactions are. So there are a number of ways that the private, that's why they're called private equity as opposed to public, is that they're private and we don't have any real sense of what's going on. There's some data available, but it's very discretionary. It means it's coming from the companies, the firms themselves. The firms make money increasingly through non-productive activities. And the way to think about this is there are two ways to make money. One is you can use finance capital and buy and sell things in the markets. Okay, so that's the stock market. You can put money in the stock market. You can buy companies. You can sell companies. That's all about trading assets. Or you can make money through productive activities where you actually invest in an entity and you're productive, and then you have profits as a result. And so the difference is important, because what the private equity firms do is they shift how much of the profit is coming from the productive side, e.g., healthcare services, as opposed to the trading or buying and selling asset side. So we'll walk through this, but that's the basic concept. So they buy and sell assets. There's something called financial engineering that I'm going to go through later on. And productive activities such as healthcare services may become secondary. And that's where we can see some real harm. So in sum, the companies or the healthcare organizations are viewed as financial assets to be bought and sold. And if you know something about shareholder value, it's what I call shareholder value on steroids. It's trying to focus only on how to maximize the extraction of wealth for your shareholders or your investors. Now, I'll give you a visual on this. How does private equity make money? It turns healthcare from a social good into a financial asset, like Lego chips, to be bought and sold. So if you think about, here's a hospital before, and here it is afterwards. So the financial firm, the private equity partners, will look at that hospital and say, oh, well, this piece is not as productive. Maternity wards are not so productive. They don't make us a lot of money. So let's just close the maternity ward. But we're going to expand in ambulatory services, surgery centers, because we know they make a lot of money, or trauma units or burn units, because we know they make a lot of money. So they pull apart the healthcare organization to figure out where they can make the most money, and they buy and sell pieces. And that's the concept. So what we say is it extracts wealth through financial strategies, not primarily through operations or healthcare services. So that's the basic concept. Now, I'm going to now move into the whole process of how private equity does this. Again, stop me if you have any questions, because I know this gets complicated. So we have a private equity firm on Wall Street, and they raise an investment fund. They get money, they solicit money from high wealth individuals, a lot of pension funds, endowments, other high wealth entities, and so they do it from these institutional investors. The industry now is about $3 trillion. So it's large. It's not as large as the publicly traded markets, but it's still large and growing faster, at a faster rate. The investors have to commit on their money for 10 years. So they have to just say to the private equity firm, we're going to give you this money, commit it for 10 years, and you can invest it and make us a lot of money. The private equity firm promises outsized returns because they say, okay, if you're going to leave it in for 10 years, we've got to show that we can beat the stock market. And that's why it's going to be valuable for you to just keep it in our fund, because the investors could be putting it in the stock market and then buying and selling whenever a stock goes up or down. So they have to get an extra return for committing to private equity. Then there's something called a 2 and 20 model that I'll go into more detail on, but it basically means that the private equity firm receives a 2% annual fee from these investors to manage the fund, and they get 20% of the profits when the fund actually closes. So after 10 years, the fund will, add up all the costs and benefits and come up with what the profits are, and then they'll be distributed. The private equity fund makes money through fees, as I've shown, and what's called a leverage buyout. Now, the key of a leverage buyout is that they use a lot of debt. So first of all, they buy a company and take it private, which means that the company, which may have been reporting, say if it's a for-profit hospital, and it had to report to the Securities and Exchange Commission, it doesn't have to do that anymore because the private equity firm is taking it off the market. And then the private equity firm uses a lot of debt to buy the company. And the debt is put on the company. In other words, the company or the healthcare organization has to service the debt. The private equity firm is not held responsible. And this is key. So the company assumes the debt, not the private equity firm. And the time horizon is that the private equity firm wants to sell the entity within about 5 years. So it wants to make, now this is a bit complicated, but the logic is this. The private equity firm raises a fund, say in 2010, and the fund will end in 2020. So, but by 2015, the private equity firm wants to start going back and raising a second fund so that their funds are overlapping. So one fund is 2010 to 20, another fund is 2015 to 2025. So in order to get the investors to re-up, it needs to start showing that it's making money by, say, year 5. So at 2010, it buys some companies. It wants to exit or make money on those companies in about a 5-year period, because then it will go back to the same investor and say, oh, look at how much money we've made for you already. And now we want to begin starting a second fund. So the timing of buying and selling the hospital entity or making money on it is driven by this logic of the timeline of the private equity fund, regardless of whatever impact it has on the hospital entity. Does that make sense? Is everyone with me? Okay. So this is now a visual of that, how that system works. The private equity firm has general partners. These are the partners that run the firm. And they set up this fund, private equity fund number 1. The general partners only put in about 2% of their own money, even less. And they raise the rest of the money, 98%, from these limited partners who are institutional investors. 35% of the money comes from our pension funds, which is a big issue that we can talk about. And, why are they using workers' capital for this kind of fund? But 35% comes from pension funds, high wealth individuals, endowments, insurance, etc. Okay, now they have a fund. They're going to buy out a portfolio company, or in this case, a hospital or a nursing home or a physician practice. And they're going to use only 30 or 40% of the equity from the fund. And they're going to get the rest as debt from creditors, bankers, bondholders, and they're going to buy this company. The reason they use debt, and I'll go into this in more detail, is that it multiplies returns, because they can then use the rest of the equity. They have more equity to spread over many other buyouts. So the logic is that we want to use debt for this buyout. And then you have stakeholders, employees, patients, and communities who are going to be affected by this. Then they buy out another portfolio company and do the same. So they're spreading their equity, they're diversifying. Then what do they get in return? Well, they get advisory fees. They can charge advisory fees to the portfolio company. And when they take this over, they also take over control of the board of directors. So they are calling the shots. And then they're essentially self-dealing, because they say, well, we're going to charge this hospital every time we do a financial transaction, we're going to charge them 1%. We're going to charge them for whatever advice we give them. And those go straight to the private equity firm up here, as well as this 2% annual fee that I mentioned that the limited partners are paying them. So they're getting fees, and they do not have to disclose what they do with their fees. They never have to account for them. They just are pure money that they can spend as they see fit. Then when they sell the company after 5 years, they're going to have to pay back the bank, right? And then they're going to take the profits that go back up. The red lines are going back up to the private equity firm and over to the limited partners. However, even though they've only put in 2% of the capital, they get 20% of the profits. That's just a formula that was set up way back in the 1980s when they first started developing this model. And the investors agreed to it because they were going to make a lot of money. And that's the way. So it's a very asymmetric power relationship, is the way I phrase it. The private equity firm has a lot more control over the fund and the terms of the agreement than do the limited partners, or who are called the investors. So now we have this model of how private equity disproportionately benefits from this model. And then they do it again. So now they have fund number two. So you have several companies that a private equity firm will own at any time with different time horizons. So if we take, for example, Blackstone, which is, maybe you've heard of it, it's the largest private equity firm in the world. It has almost 500 companies that it owns at any one time. And so Blackstone has moved into healthcare. Well, think about that. Then what happens is, given how diversified their investments are across 200, 300, 500 companies, if any one company goes down, if it goes bankrupt, so what? So what? Because they're making money in so many different ways that they can afford to have one or two companies or 10 companies go bankrupt because they're diversifying their risks. However, the risks fall on this healthcare organization and the patients and the stakeholders and the employees. So that is how the whole model is very asymmetric in the power relations and who bears the costs and who actually has the benefits. Yes, go ahead, Therese.
Sorry, I'm not super familiar with private equity. So is the reason the portfolio company agrees to this transaction because they're close to being bankrupt and they expect greater profit?
So that's the argument. That's a great question. That's the argument that private equity firms make. However, if you go back to the earlier slide, I said that only 2% of their money goes into what is called, distressed investing, or, saving bankrupt companies. The reason that a portfolio company, or I should just say, a healthcare organization may decide to do this is that one, for example, a doctor's practice may decide that, there's too much paperwork, and the private equity firm says, I'm going to come in and I'm going to take care of all your billing, all your administrative work. You can just focus on healthcare. And so it seems appealing, even though there are hidden costs to doing that. And we can get into that story. Or there may be a hospital CEO, and we're going to see in this case, where the hospital CEO actually gets in on the deal. So the hospital CEO gets to take a share in the buyout, and then he gets big returns and can exit. So in some cases, there's collusion. In other cases, you may have a provider. So in mental health clinics, where they'll say, oh, I'm exhausted. I've built this practice for 30 years and I really want to retire, and I can't find anyone to buy it. And private equity comes along and says, I'll buy it. And then they're going to buy many of these and roll them up into one big system that leads to more consolidation in the industry. So there are a number of different reasons why the private equity firm agrees, or I'm sorry, the company, the healthcare organization agrees to go along with this. And in many cases, they are good reasons because they've done their life's work. And in other cases, there's collusion. Does that work? Okay, Mackenzie?
Hi, yeah, I had a question. You mentioned that after 5 years they sell off the hospital or whatever company it is. Who tends to buy it off of them? Is it other private equity firms or like in the case of hospitals, like a big for-profit chain typically?
So that's another great question. It turns out that in some cases, it varies. In some cases, say you have small doctor's practices, what the private equity firm, it acts as kind of what I call market aggregator. So they will buy up a number of physician practices and create a larger system. And then that becomes useful for a large hospital system. And then the hospital system may say, oh, I want to integrate that large doctor's practice into my healthcare system, because now we see there's a lot of integration of physician practices and physician companies into the larger hospital system. So that may be what we call a strategic buyout. In other words, there's a healthcare organization that sees the value of buying this. But in many, many cases, and increasingly, they're bought out by other private equity firms. So think about going back to that idea of the different funds. So say you have private equity firm number one, who has a fund that was created in 2010, and they need to sell something or realize a profit by 2015. It could be then that there's a second private equity firm that raised a fund in 2014, and oh, they need to buy things. And so they're going to, private equity firm number one is going to sell the healthcare organization to private equity firm number two, because in the one case they've got to sell, but in the other case, they've got to show their investors that they're buying. And so there is a lot of horse trading among the private equity firms themselves. So that's a great question, and you've nailed it. That's happening increasingly. In fact, there's an article that shows that some in recent years, something like over 90% of the doctors' practices that have been bought have then been bought and sold to other private equity firms. So great question. Any others? Okay, so now you get the general picture and why the private equity firm is so powerful. These relationships are all explained or laid out in what is called the limited partner agreement. So it's a legal agreement that the investors sign with the private equity firm, and they can't get out of it. So these are very kind of institutionalized agreements that have been set in stone now for 30, 40 years. And it's difficult to change them, because if, say, a pension fund goes to a private equity firm and says, well, I really would like to change the terms of agreement, the private equity firm will say, well, why? You've agreed to it in the past. And, if you really don't want to do business with us, we don't have to work with you anymore. So there's a kind of implicit threat that if the investment fund and if the investors don't go along with this agreement, that they may lose out. And there are reasons that they think they need to have some of their pension funds in private equity. And that's a whole other story that we can get into if we have time. Okay, let me go on then. So to summarize this classic buyout model, the debt is the core of the business model because it multiplies returns. There's low risk and high reward for the private equity partners, but there is relatively high risk for the limited partners and the portfolio companies. There's moral hazard embedded, and this is an economic concept, and it simply means that the private equity firm is taking risks with other people's money, and it gains on the upside, but it has very little to lose on the downside. And that's it's an economic term called moral hazard. The taxpayers are subsidizing this because the private equity firm gets to deduct all the interest payments on the debt from their tax returns. And so that's another way that they can benefit. And so that summarizes a number of the ways that there are advantages for the private equity firm with this business model. Now I'm going to go into a little bit more why debt is so important. So here you have a capital structure, and the debt level of the company depends in part, again, let's call it a hospital. The debt level depends in part on how large the system is. And then the strategy to make money is either through operational strategies, and all hospitals can make money by either improving revenues or cutting costs. And in some cases, they can do it through upcoding or things that are marginally legal or illegal. So they can make money on this side. They can also make money on what I call financial engineering, and I'm going to go into more detail there. And then the outcomes are that they manage for cash flow. Now, this is an important concept. They are not trying to maximize profit at the level of the individual hospital or hospital system. They are trying to maximize profit at the level of the private equity firm. And they do that by managing the cash flow at each of these hospitals. So they want to manage, they want to push through as much cash as they can in order to service the debt, right? Because there's a lot of debt. So they're focusing on pushing through, volume, getting more and more cash, either through better revenue or reducing costs, so that they can service this debt load that has been laid on the company, organization. And what happens is that in small buyouts, they're going to have to rely more on the operational stuff because they can't use as much debt. But most of the private equity capital is involved in these financial engineering strategies. And let me go and talk more about what these are. Okay, so high debt, that's one financial strategy. I mean, if you look at most hospital systems or nursing homes, they don't have a lot of debt. They can't afford a lot of debt. And in publicly traded companies like Hospital Corporation of America, the shareholders would revolt. If the debt gets too high on a publicly traded hospital, the shareholders would pull their money because they think it's too risky. But in this case, the private equity firm is not beholden to anyone. They have a 10-year lifetime to do what they want. So they use a lot of high debt, and it increases bankruptcy risk. It may drive closures, understaffing, layoffs, and low wages. They, as I mentioned before, they have these excessive advisory and transaction fees that are charged to the companies. They have asset stripping, and I'll talk more about this in the cases that I show you, but they sell hospital property. They sell medical buildings, they sell real estate, and they take the profits and they pay themselves dividends. So they don't sell a property and reinvest it in the hospital. And it's the private equity firm, not the hospital, that keeps the rewards, the returns. There's something, this is dividend recapitalization. This is a very fancy word, and it simply means the following. The private equity firm, if it's finding that it can't sell a hospital when it wants to, it can take out a loan, an additional loan, and put more debt on the hospital and take the proceeds from the loan and pay itself a dividend. So the hospital is even more indebted than it was from the first buyout. And then that even makes the hospital more at risk of failure. So this is another financial engineering strategy that nobody else would think of using or can't use, but that private equity has gotten away with using. And again, I'm going to show you a study soon. Okay, what's different about publicly traded and private equity owned for-profit organizations? So you can think of Hospital Corporation of America or Tenet, some of these big. Okay, here's publicly traded companies versus private equity owned. I've already mentioned the capital structure. The debt is much lower in this case, so there's more financial stability. The regulatory oversight in these cases is high, and in these it's very low or none, as I said, because the entity is taken private and does not have to report financials. The risk taking is very low here, but much higher in the private equity owned corporations. Again, because the private equity firm is going to walk away from this. Asset sales are used frequently and rarely in the publicly traded corporations. Debt for dividends, rare but frequent in private equity owned companies. Fees paid by the enterprise, none here but large, the transaction and advisory fees. Taxes, you pay the corporate income tax here. Private equity firms get to pay a lower capital gains rate. And this goes back historically when they were able to get that established, and there's been no successful change in that rate. And the reputational risks, they're very high. If something happens to a publicly traded corporation like Tenet Hospital, the shareholders know, or even a nonprofit, the public knows. But in a private equity owned situation, the private equity firm is behind the scenes, and the public will tend to blame the hospital. And we're going to look at Steward Hospital in this case in a minute. How many of you have heard of Steward? The Steward healthcare system? Okay, I'm going to show you in a minute. So those are the differences between publicly traded for-profits and private equity owned for-profit entities. Okay, so now I'm going to switch to Steward. Steward Healthcare is probably the largest disaster in healthcare history since maybe 2000, when Hospital Corporation of America was found to have fraudulently billed Medicare for over $2 billion. And it was a big deal back in 2000. But nothing has been like this case that I'm about to show you. And this is Boston. This is current. The ongoing bankruptcy is happening right now. And so it gives you a sense of how this is playing out in our real world. So any questions before I go on? I think all these ideas would become clearer when you see this case. Okay, so the key actors in the Steward Healthcare saga are Steven Feinberg was the founder of Cerberus Capital, a private equity firm, net worth of $5 billion. He extracted $800 million from Steward in 10 years. The next one is Ralph de la Torre. He was the CEO of the hospital system, and he was in collusion with the private equity firm. And he had made $250 million in just the last 4 or 5 years. And he's got a $40 million yacht in the Galapagos, among other things. Then you have Edward Aldag from Alabama. He is the CEO of what is called Medical Properties Trust, which is a real estate investment trust. He extracted $2 billion in rent from this healthcare system in 7 years, and his net worth is, in the hundreds of millions. So those are the 3 actors. And now I'm going to tell you the story. How did this happen? Okay. So we go back to Steward Healthcare in 2011. Cerberus Capital bought 6 Massachusetts Catholic hospitals for $245 million in equity, and used 73% debt. So the rest of it was paid for. The whole cost was something like $850 million. It was called, the hospitals were called Caritas Christi. They were in and around Boston, and they were renamed Steward. Now, Ralph de la Torre was the CEO at the time. Now, all hospitals were doing not very well in this period because they had just gone through the Great Recession. But not all hospitals ended up being bought out by private equity. Very, very few did. But Ralph de la Torre thought that, well, the way to really make sure they're on stable footing was going to be to get an infusion of cash from private equity. So that was 2011. 2011 to 15, the Massachusetts Attorney General set the conditions of sale. And it said that, well, if you're going to turn a nonprofit into a for-profit, then you have to put in about $400 million in investment. You have to maintain charity care. You can't sell any of the hospitals. You can't have closures or layoffs. And after 2015, the Massachusetts AG looked at this and decided that Cerberus had maintained most of the agreement. They actually closed one hospital. They did do some layoffs. They sold some medical buildings, and the 400 million in investment they did put in, but they used debt. They used debt and they put it on the hospital system. So they weren't using any of their own equity. So, but with this, Massachusetts General, and it could be that they didn't know what else to do. They agreed that Cerberus Capital could continue with this. In 2016, immediately after that, Cerberus sold all the hospital property, divided the hospital property into an operating side and a property side. It sold all this hot property for $1.25 billion to Medical Properties Trust, which is what's called a real estate investment trust. And I'll tell you about that in a minute. Then the hospitals have to pay inflated rent on properties they used to own. Okay, everyone with me? Now what happened, Cerberus took 500 million and paid itself dividends. So, you've got a 5-year window, and Cerberus wants to give some money back to its investors after that 5-year period, and it couldn't sell the hospitals yet. So it went for the sale leaseback where it sold the property. It took 500 million and gave it to itself and its investors. So in 5 years, it more than doubled its equity investment. Okay, everyone with me? So that's the way Cerberus is getting its money out. Now we've got to look at these other actors. What's going on with Medical Properties Trust? I should say that as soon as Cerberus bought the hospital system, Ralph de la Torre, who was the CEO, got rid of all of the board, which were mainly Catholic citizens and other people in the community. And the board was taken over by Cerberus private equity partners, plus one real estate developer, and Ralph de la Torre. So that means that there were not medical people on the board of the hospital system calling the shots. There were only financial actors on the board calling the shots. Okay, now let's go on. Let me talk about this Medical Properties Trust. This is really in the weeds, but so you've got this real estate investment trust. What's the deal here? Well, first of all, it's set up as a tax-exempt pass-through entity to invest in real estate. So without getting into details, there was a law passed way back in 1960 that said you can set up this real estate investment trust as a nonprofit, and it's a pass-through. So say I want to invest in real estate. I'm going to put money into this real estate investment trust as a retail investor. And then they're going to invest the money. And then they're going to give me back returns. And it's a pass-through. So they're not making any profits, so to speak. They're just like a pass-through investment entity. And so, but they get to be tax exempt. And they're not, and so 90% of the returns go back to these investors. And they're supposed to be arm's length, which means they can't influence the operating company. Okay? Now, what happens? Well, the sale leaseback model it's very attractive to the investors because it has long-term predictable returns. So the private equity firm is going to get its money out very quickly and pay itself dividends. Why does the Medical Properties Trust going to spend 1.25 billion to buy something like 9 hospitals at that point? It's going to lease the property back to the steward, to the operating company, the hospitals, in long-term leases with inflated rents, with automatic increases of like 2% a year. It's willing to pay the upfront cost because of this long returns. The hospitals, now these are hospitals that were formed in 1900, and they owned their land, but the land is in central cities. It's the center of the community. So that's very, very valuable property. And so the market rate for the rents is sky high compared to the value that the hospitals were getting, which they paid almost nothing for it years and years and years ago. So that's why the rents are very, very high. And they also have something called a triple net lease. And this is really where it gets in. Steward hospitals not only pay the rent that increases every year, but they have to pay all the costs of maintenance, utilities, repairs, taxes, and insurance. So that's like if you were renting an apartment and the toilet goes bad, you have to pay the plumber to fix the toilet. So it's a very asymmetric power relationship. The private equity firm says this is fine because they're gonna get out. They're gonna sell the hospitals. Medical Properties Trust is going to make its money. The hospitals, patients, communities are saddled with all the costs. Okay, that happened in 2016. Now, why split this hospital into operations and property? You know, you could just have, for example, you could have people buy stock in the entire hospital system, but it turns out that investors only value the real estate. So in a valuation on the stock market, the hospital, so I'll give you an example. This is the various hospitals that Stewards bought afterwards. It ended up with some 40 hospitals. It bought 8 hospitals, and this is in the 2000s. It bought 31 hospitals altogether. In 2017, it started with these 8. It bought the hospital system, 8 hospitals for $312 million, but sold the property for $302 million. It means that the value of the property is 97% of the entire hospital system. It means that Wall Street does not value skilled physicians and practitioners and people who save lives. They only value the property. And this is another example, 18 hospitals it bought for $2 billion. This is in Utah. And the property value was $1.5 billion and 75% of the value. 5 hospitals, again, 82%. Now, it sold all of this property to Medical Properties Trust. So you have a deal. You have 2 partners. You have the private equity firm and you have the real estate company. And the private equity firm buys the hospitals and immediately sells them to the real estate, the property to the real estate investment trust. And then that payment helps finance the debt. But increasingly then the hospital system is indebted to the real estate company because the real estate company is financing all of that debt. Got it? Okay, this is what you call financial engineering. Okay, now what happens? So the Medical Properties Trust, what is in it for them? Well, these are quotes from Edward Aldag, who you saw. He says, we target hospital property because we saw that hospitals are certain to generate growing amounts of profitable revenue. We decided let's capture a portion of that revenue that's absolutely have to be paid to occupy delivery systems. And then he goes on and says, Finally, we always address two primary questions when underwriting an investment in the property. Is this hospital truly needed in the market? And would the community suffer if the hospital were not there? So he's calculating that they're gonna sell these properties for a lot of money. They're gonna charge a lot of rent. The rent will go up. The rent digs into the net revenues of the hospital, because now the hospital is paying a lot more than ever paid. And he's calculating that somebody's going to buy them out. If this hospital system goes bankrupt, the community can't let the hospital fail. The state can't let the hospital fail. He's banking on the fact that this business model will allow them to make a lot of money, and someone will make sure that that hospital keeps going. Everyone with me? Okay, so what happened? Now we're at 2019. They bought 31 more hospitals, so they were up to over 40, and then they sold some hospitals. So in 2019, they had about 35, 36 hospitals. Steward was found to be the worst performing system in Massachusetts, with the highest debt, higher than average patient falls, infections, and patient readmissions. Investigation found vendor non-payment. So they were not paying their vendors for all the equipment that they and supplies. There was gross understaffing. Doctors were constrained in what they were able to do. 2020-21, Cerberus now wants to get out. Remember, it has a 10-year fund, and it wants to get out. So it sells the debt-ridden chain to Ralph de la Torre, who is the CEO. And how does Ralph do it? Well, he goes to Medical Properties Trust and gets $335 billion to pay off the private equity firm. The private equity firm exits. And Steward avoids bankruptcy in that year because it gets huge CARES Act grants under COVID. Here, Cerberus ends up with at least 800 million in pure profit in less than 10 years. Okay. And by 2021, MPT, the real estate company, is Steward's largest creditor, landlord, and held 10% equity. I won't go into the details on that, but it was allowed to actually own part of the operations too. So it's got its hands on the whole hospital system. Okay, now what happens? Steward's financials collapse in 2024. It had paid $2 billion in rent in just 7 years. It owed $50 million in back rent and $341 annual million in rent going forward, because the rent is increasing. It had a debt load of $9 billion to Medical Properties Trust, the vendors and creditors. It owed $290 million in workers' back paid wages. Okay. Traco. Now, this is another scam. The company, Steward, had set up a medical malpractice company to take care of medical malpractice. It established that in the Cayman Islands, and then it moved it to Panama, where it would be safer from scrutiny. And it drained 100 million. It virtually drained all of the money for malpractice to pay off its debts, pay off some of its debts. It faced 24 vendor lawsuits for not paying, and hundreds of malpractice suits. It faced lawsuits for role in defrauding the Malta hospital. That's another scam it got involved in. In 2020, de la Torre got a $111 million dividend, annual salary of $4 million plus bonuses. Now, because there was no medical malpractice, there are patients who have sued, but there are no assets to go after to cover the medical malpractice. Okay, now we go into the final thing. What happened to MPT? It had invested 4.5 billion in Steward, gained 2.5 billion in rent. And here's Aldag with his compensation. But the Steward properties were like 25% of its portfolio. 10% of properties also were owned. It owned Prospect Medical, which was another private equity owned hospital chain. And then there was others. So it is really dependent on the Steward for its income coming in. But Steward is going down the tubes. So it's what we often call a Ponzi scheme, because they are both indebted. So if any one of them goes down, then the other may go down too. And so here what we see is its stock, you know, this is 2015. It's going nicely. It just explodes in this period when it's, you know, doing all these deals with Steward. Keeps going up. This is the COVID period. Then it goes up more and then it crashes. So it's in bad shape right now. Steward's in bankruptcy. Harm to patients. There were at least 15 deaths and injuries, thousands of patients, life-threatening care. Sick patients collapsed. One died waiting in a line in the emergency room. Emergency room wait times were astronomical compared to the national average. The Loan Institute gave Steward an overall C for patient outcomes. Boston Globe's identified 300 deficiencies. And this Traco medical practice insurance was drained, and it can't pay for over 500 medical malpractice claims. Here's a new mom. She needed a piece of equipment after she gave birth. The vendor had taken it away because the hospital hadn't paid for it, and she died. And then there were all sorts of other bat infestations, poor facilities, etc. Total, there were 45 hospitals, 12 closed, 14 were sold, many to private equity firms. 2 were bailed out by Massachusetts. So Massachusetts has already put in over $1 billion to save a couple of the major hospitals. 9 have no buyers. And then 4,500 workers lost their jobs. And the legal actions, there are Senate hearings, there are hundreds of lawsuits, but there are no assets to go after. And Massachusetts just passed a law banning REITs and other things. But the healthcare laws did not anticipate this kind of financial behavior. So the law makers are scrambling. You know, we have healthcare fraud laws about Medicare, but this is all about financial dealing that is not covered by laws. It's virtually all legal. Okay, so that's Steward. Now, it's 10 o'clock. I know we have another almost half hour, 20 minutes. I have some quick slides that show you some of the trends and some of the evidence that is more general, not just one case. I can go through them, or I can also stop here and we can take some questions. Maybe we should first take some questions, and then I can skim through the rest of these slides, and you will have them. They're very easy to read if you want to. So let's stop and let me hear questions or comments before we go on. Zach.
When you said originally in the first part of the presentation that 90% of physician practice is owned by private equity or sold to other private equity firms, it did bring up the idea of a Ponzi scheme to me. And then when you mentioned that that is effectively part of their business model, do you think that a large part of private equity's industry is essentially a Ponzi scheme where they just keep selling these businesses that aren't profitable. They just get more money from institutional investors who are attracted by these unregulated returns that they're seeing with possibly shady accounting. And do you think that's like a industry-wide problem, or is that just specific to this Stewart Hospital case?
Yeah, so that's a great question because the industry will also often say, "Oh, well, that's just a bad apple," you know. And what I've got, there's an increasing amount of econometric studies that go across, that are large data sets that demonstrate more of this. I wouldn't call the Ponzi scheme concept, it has a very specific meaning. And it involves when there are two partners that essentially, or a chain of people that are dependent on one another. So if one goes down, then the whole chain goes down. So that's a little bit different than what is happening here, because if private equity sells an entity to another private equity firm, you know, they'll just do the same thing over and over again, but it's not as if it's a Ponzi scheme in that sense. What we find is that, you know, this is the worst case scenario. You know, I show it because you can see how much can be done that is legal. However, you know, there's a lot of variation, and it depends in part on the underlying assets of a given entity. So for example, if you have a small business physician practice, initially they can't put a lot of debt when they buy it because there's not the collateral to do so. However, what they do in physician practices is they create a platform and they buy one and then another and another and another. As the platform gets bigger, they can put more debt on the platform that owns many practices. So the use of debt increases over time. But there's variation. We have examples of very small boutique private equity firms that don't do this kind of stuff. They actually specialize in healthcare. They try to do the right thing. We have examples like that. However, they're small. And so most of the capital is found in these financial engineering schemes. So again, there's a lot of variation in private equity behavior. However, most of the money seems to be in this financial engineering side. And that's what the new econometric studies are showing, that on average, the negative outcomes based on private equity ownership are striking. Does that answer your question?
Yeah, it does.
Okay, thanks. Ariana?
Hi, so I was just wondering, in terms of like the types of hospitals that these private equity firms are like targeting, is it mainly those who are like about to go bankrupt, or is it those like who are serving like large urban centers? Like, I guess how do they like like, I don't know, pick like the hospitals that they
Right.
acquire?
Right. So again, private equity firms claim they're saving distressed entities. But as I mentioned, only 2% of their money goes into what we call distressed investing. That is, buying companies that are about to go bankrupt. So what we find is that they look at various factors, that they do what's called a due diligence that looks at all the different factors that may allow them to make money on a deal or not. And many times they're buying other for-profit hospital systems. And that may be because the owners want to get rid of them and they want to cash out. It may be because there's collusion, as I said, where the CEO becomes part of the deal. If they go after nonprofits, they have to convert them to for-profits. And that means going through the state AG. and that setting certain conditions. But as you saw in the Massachusetts case, and Massachusetts is one of the most highly regulated states in the country, those rules were not sufficient in this case. They often buy hospitals from other private equity firms that are trying to get rid of them. And they have been going after rural hospitals because they can consolidate them and, basically consolidate and get rid of one of the hospitals in one community and consolidate services. So there are many different attributes, but the driving force is not simply buying the hospitals that are going to collapse. I mean, think about it this way. Private equity wants to make money. And so they want to go after what are called good assets. They don't want to buy a hospital that's completely falling apart, and then how are they going to make money on it, right? So the idea that they're only getting, buying hospitals that are really suffering just doesn't hold up when you look at all the different hospitals and nursing homes and physician practices. So we've been talking about hospitals, but they've been active across the board in every single aspect of healthcare at this point. Mental health, home health, hospice, physician practices, primary care, all of the different segments now have substantial private equity ownership. Does that answer your question?
Yeah, if I may, can I ask a follow-up question?
Mhm.
So how are states regulating these acquisitions, if at all?
So I have a slide on that hopefully we can get to, but basically this has been a wake-up call for states. And so there's Massachusetts has the strongest law now that it passed. It requires much more transparency in ownership structures, who owns what structures, and then they have the owners have to file notices with the state every time there's a financial transaction, a buying or selling of an asset. So there are a whole set of things that Massachusetts has put in place now. They just passed a law earlier this year, and now several other states are trying to follow suit. But most of the states have new transparency laws and notification laws, but they don't, for example, ban private equity, nor do they ban real estate investment trusts. Excuse me. Other questions? Alexander.
I was wondering if any of the major players in this scheme have faced any significant legal consequences.
Not really. It's all pending. So there are various ways you might think of going after Ralph de la Torre, but as I said, all of the real estate there's nothing illegal about selling your property. There's nothing illegal about charging high rent. There's nothing illegal about, delaying vendor payments. Then the vendors have to file individual lawsuits. So there are lots of lawsuits pending, but there are almost no assets to go after. And that makes it a real problem. And so, there's been a little bit of Medicare fraud that Stewart has paid, but that's not where the real problem is. The real problem is in all these financial deals that they've made. And that's why states just were not prepared for this kind of behavior. Other questions? Let me just go through quickly a few of these slides to give you a sense of scale and scope, and then I'll try to leave time for other questions. Okay, so here's the annual private equity deal count in healthcare. So the cumulative deals amount to 1.5 trillion, 15,000 deals in 25 years. 25-fold increase in deal value each year. So that means that in the early 2000s, you saw very, very little. This is one big buyout by of Hospital Corporation of America. So basically, you see this was pretty tame, and then an acceleration in the last 10 years. Okay, so that's the annual deal count. And then this is private equity penetration in the physician practices. So you see almost every specialty, and they've penetrated those practices that are most lucrative. You know, dermatology, you know, people who want to have discretionary income, or gastro, urology. It is, but so it's up to about 15%. So it's, you might say, well, this is not a majority. It isn't, but they are having a disproportionate effect on the competitive conditions in each specialty. And they are also paving the way for, you know, well, if private equity can do this kind of financial engineering, why can't we too? So there's some mimicry going on. Okay, then we have healthcare outcomes. Now here's the quantitative evidence. First of all, my argument is the quality of care equals the quality of jobs. And you all know this. I mean, it depends on the staffing levels, on how skilled the workforce is, et cetera. And what we see is that most quantitative evidence is looking at healthcare financials, Medicare cost reports, or patient outcomes. And there's very little on labor, which is a great omission that I hope gets fixed in the meantime. Because in between the financial deals and the patient outcomes are the employees, the doctors, nurses, and the workers who are suffering from understaffing and inability to provide the kind of quality care they want to. The hidden costs are borne by the professionals, because the labor costs are the easiest thing to cut. So labor costs are, quote, variable costs, and they count for at least 50, 60, sometimes 70% of the operating costs. So they're the easiest to cut. The results are high quit rates, union organizing, and strikes. So we've seen massive increases in the turnover rates, in unionization, and strikes in healthcare over the last several years. This is a study of nursing homes. And what it's a study that uses econometric research from 18,000 nursing homes between 2000 and 2017, compared for-profits to private equity owned homes. And what they found is that the Medicare billing was 11% higher in private equity owned homes. The frontline nurses spent fewer hours with patients. To compensate, the homes made 50% greater use of antipsychotic drugs, and the mortality rates in private equity owned homes were 10% higher. That equals almost 23,000 premature deaths. So that is the gold standard study in nursing homes. Here's some on hospitals. This is all these are very rigorous studies. On longitudinal Medicare claims data, compared hospitalizations 51 private equity hospitals to 259 matched controls. So you've got these two matched sets. And the hospitals with private equity ownership had 25% higher acquired infections and 27% higher patient falls. Again, you're cutting staff, so what's the result? Here you see the results in terms of patients. Here's another one. This looks at the assets of private equity acquired versus control hospitals. Again, it was published in JAMA. It showed that here the private equity owned hospitals versus the matched controls, they're the similar until the private equity buyout. And then you see private equity disinvesting So when private equity say it invests, that's really a misnomer, because it like Steward, it stops investing in the hospitals. It in fact may, you find, the hospital infrastructure starts deteriorating. They stop paying vendors or et cetera. So you see that the private equity owned infrastructure is much lower in the private equity owned hospitals compared to the controls. Here's another one on physician practices. Harvard study, longitudinal Medicare claims data compared to the private equity acquired physicians practices and the PE owned matched ones, non-PE owned matched ones. The private equity ones had 20% higher charges per claim. So they're finding out ways of upcoding and boosting revenues. Increased number of new patients seen, 38%, while the number of physicians stayed the same. So the workload, the work intensity of the physicians increases. And now another one from Health Affairs. Again, private equity owned practices matched to non-private equity, and they found the private equity owned practices save money by replacing physicians with advanced practice practitioners. So they're more likely to use nurse practitioners than real physicians. And then I don't know, we're almost at the end of our time, but let me just say this. Private equity has been responsible for owning a disproportionate share of ER services that are outsourced. So across the board, hospitals are outsourcing their emergency rooms. They contract with these staffing companies. And there are two that are private equity owned that control 40% of the market. One is Envision and the other is Team Health. Envision is owned by KKR, Team Health by Blackstone, and they employed some 90,000 employees. Envision, in the meantime, just went bankrupt as well due to private equity ownership. But their business model was that they could charge higher out-of-network fees because they did not share the insurance contracts that the hospitals used. Is everyone with me? So they could charge out-of-network as opposed to in-network fees, and they were responsible for surprise medical billing. So suddenly people who go to the emergency room are charged with astronomical charges because they don't know that the physicians in the emergency room are actually employed by an outsourced company, in this case, Envision or Team Health. So this led to massive increases in what patients were paying for their services. It led to legislation called the No Surprises Act to ban this practice. And so I won't go into the Envision case, but it just briefly, it bought up all these practices, but used leveraged debt, a buyout, and it had 6.3 billion in loans, and then it went bankrupt because its business model wouldn't work. I have a couple more slides. I'll just say the same thing is going on in air ambulances, where there were two private equity owned carriers, controlled 65% of the market, had average charges of $48,000 compared to the national average of 28,000. And this is a chart that's from the Brookings Institution. You can look at it, but the private equity owned air carriers are up here. Now, this practice was subsequently banned, went into effect in 2022, but prior to that ban, this is the kind of thing that was going on. And it particularly hurt the rural hospitals and rural towns where hospitals have closed. Okay, I don't have time to go into policy implications. I'll just say that there are This is a general regulation to rein in private equity. It's called the Stop Wall Street Looting Act. You can read the details, but basically it talks about creating transparency, limiting leverage debt, discouraging financial engineering, closing loopholes. The same kinds of things we've talked about are in this bill. This bill was sponsored by Elizabeth Warren and Congresswoman Jayapal and others. And in this healthcare specifically regulation, moving to state oversight, banning sale leasebacks, requiring minimum staffing levels, tightening and enforcing antitrust laws, etc. And I'll just show you, there are 2 laws that were proposed in last year, one by Elizabeth Warren and one by Markey. Both of them are from Massachusetts and were particularly affected by the Stewart case. And so they've put into effect a series of suggestions. Of course, none of this is going forward given the current political situation, but you can see the kinds of policy suggestions they are making. And then finally, this is the Massachusetts healthcare law passed in earlier this year, which is the toughest law now on the books. So it requires advanced notification of transactions, public reporting and oversight, penalties for noncompliance, prohibiting sale leasebacks, and more ability to pursue private equity under the False Claims Act. So a series of things that you can Google any of these laws and find out exactly in more detail what they say. And then finally, here's a list of additional resources that you can use